which is a building which is on fire.
So it's rewarding work, but I guess I didn't know it would be as difficult as it's turned out to be. But at the same, I really wouldn't do anything else. I really love it.
Yeah, you might be the only CMO I've ever talked to that has actually used the word easy in the same sentence as being a CMO, because you wouldn't normally think like that. Hello, and welcome to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. I'm your host, Lee Scheinbart, and this podcast brings you stories and wisdom from some of the best CMOs in healthcare today. The leaders on this show face some of the toughest challenges in healthcare, and they will share with you their insights about the role and the responsibilities that come with the title of Chief Medical Officer. Today, our guest is Dr. Kristin Mascotti, the newly promoted Market Chief Medical Officer for Greater Colorado and Kansas at Common Spirit Health in the Mountain Region. Dr. Mascotti earned her medical degree from the University of Minnesota and completed a residency in anatomic and clinical pathology at Hennepin County Medical Center in Minneapolis. Dr. Mascotti returned to the University of Minnesota to complete a fellowship in transfusion medicine and was one of the first physicians in the country to earn a Master's of Science in Healthcare Quality and Safety Management at Thomas Jefferson University's School of Population Health. Dr. Mascotti has recently been recruited to serve as a founder and faculty for the National DYAD Leadership Certification Program for the American Association for Physician Leadership. Kristin, welcome to the show.
Thank you, Lee. Excited to be here.
Do you remember the first time we actually met in person?
Oh my gosh, it was quite a number of years ago. It's been a fantastic relationship, and you've helped me so much along the way. So absolutely.
We met at the AAPL Spring Conference. This is when we met face to face. We had been chatting and talking, and I'd been visiting your prior institution, but we met face to face in Chicago, as I recall.
Yeah, that's exactly right.
And now we're here on this podcast.
Thank you.
I think this podcast is somewhat a direct result of meeting chief medical officers like yourself. It was the beginning of my recognition that CMOs want more opportunities to talk with each other and to learn from each other. So let's begin and help our audience understand what was your journey like to becoming a CMO.
So thanks, Lee. You know, mine started, I think, a little bit different. I'm an anatomic and clinical pathologist and a transfusion medicine doc by training. And so that's, I think, an unusual path. Usually it's a hospitalist or ED physician. But I actually got interested in quality pretty early on. And my projects as in transfusion got bigger and bigger. And it was from there that I thought, well, maybe I'll get some training in this. And so I went to the AAPL. I did get my CPE, and in that really saw the quality courses there and just enjoyed them. So I knew that's what I wanted to do. And from there, I engaged, as you said, into my master's program. And when I was looking at master's, everyone knows what MBA is. Everyone knows an MHA. But I looked at the program and this MS HQSM, I thought no one's going to know what this is. This is too many letters. It's confusing. And, you know, I went back and I said, no, I'm really, at a point in my career, mid-career, that I want to do what I like to do, and I'm going to do quality. And so I did do that. I had a mentor at the time at the University of Minnesota who said, if you're really going to do this quality stuff, because no one wants to do it, then I want to introduce you to someone. And he actually introduced me to the CEO at the time at the University of Minnesota. I met with her for a cup of coffee. There was no job. And I just told her what I was doing, what I was working on in my master's, how I had worked to change physician, behavior and thoughts and align with them. And basically within a month or two, they hired me as the vice president for clinical quality at the University of Minnesota over 8 hospitals. So that was a new role. I definitely reached out to my colleagues across the country because there were a few transfusion medicine physicians who had become early CQOs at Mayo out in California. It was really as a chief quality officer that I started. What I realized is as you had a degree in quality and could align and change physician practices, this became a pretty sought after skill. And so a job was actually created for me in California, over 4 hospitals. And I'd been in Minnesota my whole life. I was really excited for that opportunity. So did move to the Southern California. I met an amazing mentor there, and I'm sure we'll touch on that. She was the chief medical officer. We did not have a chief medical officer on our pediatric side, which was about the 8th largest children's hospital at the time. So I leaned into that role for 2 years. So I just stepped up and said, I'll lean in. And then we actually trained a great pediatric hospitalist who's still there, and he took the role. And then my chief medical officer would take these incredible vacations, and a lot of things would happen in her absence when I was leaving up. Joint commission would come, sort of a trial, things you learn quickly. And that's how I leaned into the role. So knew I wouldn't stay in California, so looked for opportunities. I was targeting Colorado and Florida. Florida came up first, was there where I leaned into the CMO role for a 2-hospital system, and now, quite frankly, wanted to get back to Colorado, and I'm very excited to be leading CMO and quality work for 9 hospitals in Colorado and Kansas.
Well, that is a fantastic origin story. And again, congratulations on your new promotion to having a wider scope and ability to impact a lot of people. So that's a big deal, and I want to recognize that. There are some usual parts and unusual parts. It is not that unusual that physician leaders rise and get recognized, and roles are created and sequences occur that allow those of us that take this path to have that impact. And in many cases, sometimes we're just simply asked, you're pretty good at what you do, but I want you to do more.
Right.
And we don't necessarily get very intentional, but it feels very much at a point in your career, you began to lay down the intentional, platforms and foundations for you to continue to grow in the role. Do I get that right about how you were both people wanted you to do things, and then you began to want to do more? Is that right?
I think that's exactly right. And by the way, I mean, some of this is spanning about 25 years, right? So at the end of the day, clinical quality, having a physician lead clinical quality, was relatively new back when I started at that. And then the position created for me in California, that was a new position as well. So that was relatively new in physicians leading quality. Obviously, more people are doing that now because it is effective. But some of that, I also thought my breadth could increase by the CMO part, because some of quality, as maybe we'll get into, I believe physician quality is professionalism. I believe it is peer review. So being able to have the depth of a CQO to really run quality, as well as the toolkit for medical staff, for governance, for credentialing, for peer review, for professionalism. That is a sort of a complete book of tools that I think is very, very important. I think sometimes CMOs are good in one and maybe not the other. They say just get that quality to someone else. But I think having the sort of a total bandwidth is a tool set and skill that can be developed over time. And for me, it's been very, very rewarding.
Yeah, I think you also hit it at the right time in the evolution of physician executive roles. I am seeing, as I converse with health systems and leaders across the country, that there are chief quality medical officer titles as opposed to chief quality officer and chief medical officer, a growing understanding that the quality of the medical staff, credentialing of the medical staff ultimately is about the safety and quality of the care delivered to the patients on the acute side. And I think that you have a real seniority amongst the CMOs with your background. And it's great that you're on the show, because I'm going to ask you some more questions to bring out things that some younger folks may want to consider as they go through this. So you ready for another question?
Of course.
Okay. So as you look back on this journey and the arrival to where you are today, I want you to take a step back and consider the following. I want to ask you what you think that your coworkers observe about you. And to me, it doesn't matter which institution you're referring to. So I know this is reasonably new in the Colorado area, so pick whatever one that works for you. But I was told, and I still believe it to be useful, that you can separate folks into 3 general categories in order to meet them where they're at quickly and not spend a whole lot of time trying to dissect them and understand their motivations. People tend to come across as either analytical, aggressive, or somewhere in the middle being diplomatic. And I can think of some physician archetypes that we could use, such as Dr. Osler, Dr. DeBakey, Dr. Fauci, as some examples. Or we can also use some women physician leaders, such as Dr. Elizabeth Blackwell. She was the first woman to earn a medical degree in the United States, and she was highly diplomatic in the way that she navigated getting into school and being recognized for her accomplishments, as opposed to Dr. Ann Preston. She was the first woman dean of a medical school in the United States, and that took some aggression on her part to break down some barriers to recognize that a woman can be a dean. And she went on to develop hospitals and training institutions specifically for women physicians. So she broke several ceilings. And then lastly, Dr. Virginia Apgar, and that is the anesthesiologist who invented the Apgar score for our newborns. Highly analytical, and took all of her residents' questions, and if she couldn't answer them, then she'd come up with something like the Apgar score so that the residents would understand what we were doing. So you look at your coworkers and how they look at you. What would they say about your category or archetype? And you can pick any others if you can think of them.
I think this is a great question and a little bit hard because sometimes you flex depending on the need, right? But I think overall the teams would say about me that Kristin is collaborative, but she's definitely willing to take on hard subjects that haven't been solved and bring groups together to find the best solutions. And some of them may not even have been created in our environments, but work together to get there. I think that's what they'd say. I would definitely say that I've been viewed as a change agent in terms of being able to transform some of the cultures that we'll talk about, as well as quality and med staff. That's what they'd say. I would be my guess.
Let's talk about that flex for a second. You said you flex. Now, it has been studied that most of us have a natural style and an adaptive style, which is that flex. Were you brought through a period of time in your leadership role that you began to fall into your natural role and learned how to flex and adapt, or that was something that came very quickly and easily to you?
So that's another great question. I think I definitely start in the collaboration, the bring people together, learn how the team is going to build to make outcomes. It's also the best product when you get key stakeholders involved and frontline individuals. There have also been times, because we'll get to the fires, right, that you have to flex and turn into a style that maybe you need to be a little bit more on the assertive side. Or I would call it courage, to be quite honest, because some of the environments that we'll talk about required a true courage to step up and say, this is what we need to do and this is why. And hopefully you've either been in an organization long enough, or you have that trust built up that people are right there with you, or you've garnished that through other conversations informally before you have to make those stands. But there are times where I think you have to really flex to courage too. And I think that's a big part of my story with some of the changes we've been able to make.
I think in medical school, we are not regularly taught about those different adaptive styles. And I'm curious if, as you finished up your training and your master's, you had mentioned some of the role models and mentors, and I'd like you to talk a little bit about them and what you garnered from those relationships, and did they help you to shape these different styles depending on the circumstances?
Absolutely. I think one of my very, very early mentors was at the University of Minnesota. He founded the bone marrow transplant registry, so just a very big figure in my specialty. He was amazing in terms of understanding and learning what it took to become a leader. I think that was more on, academic early career side. AAPL has been where I've gone to get my true education to be a physician leader, through the CPE, understand what physician leadership is: quality, financial, managing performance. So that was a lot of my early sort of learning. But then when you get on the job, where are those great people that you want to be like? And I can think of two, actually. One was a CNO at the University of Minnesota, Dr. Laura Reed. She's fantastic. And the other was Dr. Sue Melman, who was the CMO at the time. in California. And both of these individuals had an incredible capacity to, not only were they so well respected and had amazing influence in the organization, but they really were able to take a team, have them understand and engage in the why and move forward, even when they were some of the hardest things to do. And so I learned a lot from them on approaches, whether it's diplomatic or otherwise, as to how to do that. I think the other thing that I saw both of them do is courage. And how do you do that in a way that you have the least negative effect when something's very difficult to implement? And so I had great mentors along the way. That would be two examples.
I love the way that you frame courage. It takes courage to make a commitment to enter the pre-medical track and go to medical school and learn how to be a competent clinician. And we kind of therefore already have that, but we tend to forget that along the way. And then, like you say, then you realize that there's a value to bringing that forward, trying to get the best possible outcome. And again, that's what physicians are trained to do, with the least negative impact, and courage as a method of delivering on the promise, I think is very impactful. What's the hardest thing you have faced as a chief medical officer, aside from the pandemic? You and I both had to manage that at our respective institutions, but what was the hardest thing you have faced so far?
So I think this is a great question. I reflected on that. I think, and it's been a few organizations, so this is not institution specific, but it's really changing physician culture for them to understand the importance of professionalism and peer review in how that impacts true quality of care. And so a couple of environments that I've been in, they didn't have solid ways of tracking or trending physician behavior. Peer review was basically looked at as physician-centric, and someone was in trouble. And so really changing that philosophy to one of early awareness, to having early interventions on the Vanderbilt models, like they've shown so eloquently, as to how that actually is tied, professionalism is tied to surgical outcomes. Getting medical staffs who had no processes or tracking and trending to a place where they actually determined that we could save physician careers. And again, this is over a span of years. I think that's one of the hardest things to do, but also the most rewarding. That's where I put that, because it's a difficult walk. It does take courage. It takes data. It takes understanding that this can be turned into a positive and actually career-saving opportunity for physicians.
Yeah, that is not going to be news to our seasoned listeners, but it is certainly of high value to those that are newly in the CMO role. And you may be blessed to have a medical staff that you've inherited that has a different perspective, but more often than not, you do have to spend the requisite time, as you said, talking about the quality of care that the physicians have in their very own hands with their peers. And it's about performance improvement, not about punitive, restrictive approaches. So that's some tough stuff. How about the biggest fire that you've had to fight that just blew up on you, and hopefully you were able to put it out? Can you speak to anything like that?
Yes, I can speak to this one. Brand new, within 3 months of my first job at the University of Minnesota, and Ebola hit. And that was, so I'm brand new as an executive within the first 3 months. And what ended up happening is no one in the state really wanted to develop a special pathogen containment unit. And eventually the state relied on the University of Minnesota to do that. And so I was chosen along with the chief nurse to build that within my first 3 months. And I thought, wow, we did incident command, and we really put together, I met a lot of people in the organization very quickly, but to build a special pathogen containment unit when there wasn't really a great model in the United States at that time was probably one of the biggest fires that was placed in a very short period of time as a new executive. And so tons of lessons learned there, but that was probably one of the biggest fires, and had to be done well, because we had seen in the country where it hadn't gone well, there were ramifications for employees, for patients, and the amount how quickly it had to come together without knowledge, that was really difficult.
What did you draw upon as a set of tools or tools in the toolbox, as we say, to manage? You're new in the role. This is a very unexpected and unusual circumstance. What did you draw on to make sure you could execute on the commitments that you were being asked to make?
No, it's a great question. So this is where we had a great leader. Like I said, that the CNO was amazing. Dr. Laura Reed, she brought together the Incident Command Center, and that was the absolute appropriate thing to do. And that we really executed on well. But I think from a toolkit, no one knew how to do this. So I really looked for best practices and went and found Emory. I mean, at the end of the day, all you can do is go talk to those who are doing it the best, and that provided our best roadmap. And so that, with bringing the teams together, including these, the key stakeholders, but the frontline staff in terms of nursing, ED, points of entry. I mean, this was a massive approach to get this built really quickly. And so I think the tools that I used were not only relying on incident command structure and great leadership, but really finding and talking to the best practices authentically and saying, this is a problem. How did you fix this? Can I contact you? What did you do about this? And then, tweaking them to our own spaces and allocation. And we did end up having some things we definitely had to work through in terms of antechambers and the like, and just relying on those who had done it and their experience, that was invaluable.
I love that, and I agree with that. Again, we're taught in school how to take a history, do an examination, create narrative around something, and as we're trying to make a diagnosis, we keep asking questions, hopefully open-ended, and hopefully to give us as much quality data as possible. You'll get the quantitative stuff through the laboratory studies later, but it's the qualitative questions that are critically important in leadership roles. Leadership puts you in places of ambiguity. You don't always have the answers, and you have to be humble enough to know what you don't know and know when you don't know it, and go look for inputs, and then sit down with a group of willing people and say, okay, with all of this information, what do we come to agreements about, and what can we execute quickly? Absolutely spot on, because I'm sure in medical school, while we both were studying Ebola, we never thought it would actually enter.
Right? No, never. I did not think that was going to happen in my career.
I can admit to you, and I wonder if it happened to you as well, because it became a national event, right?
Right.
It's
here.
It
was. Right.
It's in the United States. And the chief medical officer, long before me at our flagship hospital, immediately called for signs in the lobby that said, if you have a fever, please turn around, right? Now, we all did that in COVID, but it was not the thought of an Ebola patient walking in with a fever, and we're going to say, please go the other way. I thought that was hilarious.
Yeah, that doesn't work.
Just doesn't work.
No.
Tell us about, as you expressing, these events and the courage and the ability to seek information, you have landed in a very unique role, and I'm very happy to again promote the DYAD Leadership Certification Program through AAPL. Tell us how you arrived at that and what you see will happen through that program and what it is for those who don't know.
Yeah, great. Well, after presenting at the AAPL about a leadership program that we did, we started talking about how these things come together and really leaning into the conversation around CNO and CMO capabilities. And so we were asked to create a program for the AAPL that's really is called the Mastering DYAD Leadership Academy. That's a certification program that'll last about 6 months. And essentially it's for CMOs and CNOs to come together. So it really has two pillars. One is to solve a problem. So take an institutional problem that you got to solve, and then we're going to use the lean principles on how to do that, except what we've done here, which is a little different, is applied them to an H&P. So it's the PDSA type of model, but we're really clinically orienting that to how we do intrinsically H&Ps. So we're going to run a project as part of it. But the other part of it, and I think the more interesting part in some ways, is we're really looking at the DYAD relationship itself. So it's not only we're doing different assessments to see what strengths our CNOs bring, what strengths the physicians bring, and what we bring independently, as well as our blind spots. And then we're going to evaluate how our leadership, our DYAD leadership, impacts teams that we're running, because there are actually scales that can show us our assertiveness and responsiveness and how that has impact on high functioning teams. So that's some of the information that I'm really excited about. It also, I think, is so imperative because at the end of the day, we know that bedside rounds, intercollegial bedside multidisciplinary rounds are effective for better care. And when we include the patient, it's the same thing for leadership. I think when we really harness the true potentials of the leadership capabilities of the clinical people with the CMO and the CNO, that really is the workforce. And I do believe that's where leadership is going. So I'm excited that AAPL is looking to now include nurses in this leadership program so that we have more of a true interprofessional development programs in education. So I think it's going to be a lot of fun. We're going to learn a lot.
For those listeners, so it is a CMO with their DYAD partner CNO, or the other way around, a CNO
Correct.
can drag their CMO in, if you will,
Exactly.
and you go through it together and work on sort of this project level thinking, this collaborative interaction, right? Do I understand that?
Exactly.
And that both individuals earn the certification upon completion of the program, which is about, 6 months of a
Yes.
program? Okay.
Correct.
I think that's awesome.
It'll be hybrid, and then they'll actually present to key stakeholders as well as at the AAPL. So we are excited about that. I just think it's I think we're going to learn a lot about the relationships. DYADs have been around for a long time, but I think investing in the true education of a team this way is novel, as well as the project-based approach. So we have done it hybrid so that we have touch points throughout the course, and then some, independent learning as well to keep things, more flexible for our adult learners. So I'm excited about what we're going to learn. I think learning about how these relationships come together in the strongest forms, as well as what happens when they don't, or how do you get things back on track, will be some of the material that we'll cover. So
good
we'll
stuff.
Mm-hmm.
Stuff. So we're going to switch gears again, and now I'm going to ask you a rather personal question, which is, what is the hardest aspect for you personally of your job and your role? You're human, I'm human. These are difficult positions to be in. What has been the hardest aspect for you personally?
I think some of it is balance in terms of, when you're working with physicians, they could be early mornings, late nights. It isn't really an off-call situation. I do give my phone number. It's widely available. So I think it's actually making sure there's a little bit of balance and making sure that you sort of have coverage when you're able to take a few days off. And that goes to training those and helping people in succession planning. So I think for me personally, that's been the most difficult part, because when things happen, say the Ebola, I will tell you that is a absolute 24/7 situation for whatever time it takes to fix. And there's more than one of those that I can come up with throughout my career. So I think it's the impact that it has on the rest of your life. I think that I'm still working on balancing. That would be probably one of the hardest things. I think another thing is having the courage to stand when you know it's the right thing for patient safety. That isn't hard for me, but it can be difficult to do. It can be difficult to do.
Yeah, back to the courage theme in our podcast today, I would agree with you, and I've stated this publicly, and it's not my own idea. Others have said it as well. We take an oath at our graduation. Different schools have different oaths, but the essence is the same, and that is to do no harm when you condense it all the way down. And not everybody in healthcare has taken an oath. Many nursing schools provide a range of different oaths and so on and so forth, but non-clinical leaders have not. And the oath empowers us to attempt to do the right thing 100% of the time with good intent. And none of us are perfect. I, too, have put myself, my courage, my role, my job, my family's future on the line by standing up for what was right. And my physician boss before me showed me how to do that because he too had to do that. And I think we become, rightly or wrongly, the clinical conscience of our organization with our nursing partners, with our pharmacy partners, whoever else, whatever we're dealing with. And without that clinical conscience, then the board can't trust that the administration is always putting the patients first. So kudos to you for sharing those things, because these are difficult things. And during the arc of our career, we do have to create teams and successions and people that we can hand off our phone to, because it is 24/7, and we do need to recognize that that's just not good for everybody all the time.
Right. I really love your idea of clinical conscience. I think that's so important, Lee. And I think it also depends on the environment that you're in. If that's been done before and that's the ethos, that's the culture, that's great. In some areas, that isn't always where we are. And I think our role as physician leaders is to understand and put, so peer review isn't necessarily about did the physician do right or wrong, what happened to the patient? And sometimes we lose sight of that as we're looking at the clinical care as to X or Y. Well, let's just start with X happened and Y happened. So it's not easy to do, but these are the small stands you can make in everyday work that actually have impact and start changing the perception and the way we think about things. But I think the clinical conscience is about what I'd say my role is in not only quality, not only peer review professionalism, but from an organization. I think that's very, very a great point and well spoken. I'm going to use that.
Go for it. I stole it. Now you share it.
Too.
That way, I'm not the only one in trouble for plagiarizing. So no, it's good. It's very good. What would you say to your younger self now that you have a couple 3 decades behind you being in these roles? What would you say to that young lady back thinking about medicine as a career and eventually thinking about some other steps along the way? What would you say?
I wouldn't have believed it was possible, to be quite honest, because this was not anywhere on my radar. It was really just make a difference in wherever I was working, and started by just taking on things others wouldn't do, which, to your point, if you can find new ways of doing that and bringing that together, sometimes others haven't done it. It ends up being publishable, and then you get more and more and more. So really leaning into roles. What would I tell myself? I guess I would say it's possible, because I didn't think it was at the time. It's possible. Take a look. Find people who have done what you want to do and talk to them. So, my first step was the CQOs, that kind of thing. And I would say that it's going to be a great journey. You're going to have broader impact, but it is not going to be an easy journey. Mm-hmm. And it looks easy until you get there. And that's what I say to my med staff leaders or whoever, boy, isn't this easy? We just go to meetings, right? But when you get to those critical decisions and you get to those elements of change, or how do we impact culture, that is the really, really hard work that you have to roll up the sleeves and do. But at the end of the day, it's really, really rewarding. So going back to the whole conversation on what felt amazing is when after 3 years you've been working with the medical staff so that they rescue physicians and get them help before professionalism issues happen. And you are out rounding and you have a nurse say, I don't know what happened to Dr. X or Y, but something's really changed and they're really doing well. And that's when you say, wow, all of this work has not only impacted nursing, it's impacting physicians and the patients. So it's rewarding work, but I guess I didn't know it would be as difficult as it's turned out to be. But at the same, I really wouldn't do anything else. I really love it.
Yeah, you might be the only CMO I've ever talked to that has actually used the word easy in the same sentence as being a CMO, because you wouldn't normally think like that. And it does look at the surface like, so look at it this way. We have a title, we have a role, we have a job, and then there's the work that we do. Mm-hmm. And I would say the first 3 are letters and titles and descriptions, but the work that we do involves 2, 3, 4 years of effort, painstaking to make the impact, and the delayed gratification should never be underscored or underrepresented, rather. It is what makes it worthwhile when you finally make that impact that has such a ripple effect in the care of the patient. So you have articulated quite a few good lessons for our listeners. What about healthcare in general, healthcare at large? What is the biggest fire in healthcare, in your opinion, right now? And what can a CMO do about that, if anything at all?
I think one of the things that's going to impact us and is impacting families everywhere is really around the cost of care. I mean, at the end of the day, the cost of care is a huge impact. I think access to care is another one, and then some of the social determinants, as we know, the disparities that exist and how we're going to work on some of that. So I do worry about the costs and then the disparities that we're having and how we're going to close those gaps. And that was a big topic of conversation at the most recent IHI as well. So those, I think, would be some of the biggest problems. How can we impact that as CMO? At the end of the day, I do believe there's a lot of waste in healthcare, a ton of waste. And so how we look at our processes that we're doing in the operating room or throughout the whole house to really identify waste with our frontline users and bring up solutions that way, I think that's one way we as CMOs can contribute. In terms of the disparities and things, the first thing to do is see if you have the data. If you have the quality data and you're acting on it, great. If you don't, try to find an area to impact with disparities, just to even highlight to ourselves and our staff and our community that we're working on it and we've identified this, and these are the 3 or 4 things we're working towards. So I think it's a start in those directions. So that might be a couple of things that we could at least start on, but these are our big, major national initiatives.
Yeah, and I think the faculty at the Jeff, for those who don't know, that's the short version of the Thomas Jefferson University and the School of Medicine and Public Health, the Jeff. The faculty would be very proud of you mentioning that there's a ton of waste in healthcare, because they drill that into your head there. And you're right, as a chief medical officer, we are much better equipped at understanding why there are so many different preference cards and why there's so many different trays that are put in the OR. Well, I trained at the University of Pittsburgh. I trained at Stanford, and this is what I use. Well, but it's costing us X, and it could be done for Y, and you'll get the same outcome. And that waste can be turned back into other opportunities. So whether or not that globally lowers the cost, I don't know, but we can locally lower the cost all of the time. And if then used appropriately, we'll have a better output for those that are in need of extra cash flows. As a leader, it is incumbent to explain the why again and again and again. Now, we may not like the why. We may have had nothing to do with the construction of the why. You and I did not have a voice in the creation of CDI as a method, and we might not have voted for it even if we had been. But the point is, it exists today. These are the conditions under which we work today. And by explaining the why and getting people on board, that's the work that we do as leaders to have an effective outcome and change, where we're going. This has been wonderful. Being a chief medical officer, as Dr. Mascotti has described, is no small task and requires both courage and intentional preparation, although much of it can be like a trial by fire, particularly if Ebola is knocking on your door. My old physician boss told me that it really is like a career in firefighting. You start when you go to firefighting school, and you train and you drill and you put on the uniform until someone says you are ready to go fight a fire. And you go out the door and you do that work, and then maybe one day you find yourself being called squad leader or captain. Mm-hmm. And then perhaps, if you're lucky enough, maybe you are the fire chief at the fire station. And my boss always told me, you cannot be a fire chief without first becoming a firefighter. Mm-hmm. Would you agree with that?
Yeah, I agree.
Oh, yeah. Well, again, yeah, you have fought your fires, and you have earned the title of fire chief or fire chief medical officer, for that matter.
I love it.
Pleasure to have you. You have been listening to the Fire Chief Podcast, the only podcast dedicated to the chief medical officer. Want to learn more about what it is like to be a CMO? Want to be on the show? Email me at leescheinbart@gmail.com or connect with me on LinkedIn. You can listen to the podcast on Apple, and you can also watch the videos of the shows on YouTube. Our show's website is thefirechief.podbean.com. I love talking with CMOs from all over the United States, so please feel free to connect with me, leave your reviews and your comments, and please share this with your colleagues. And in the words of Sergeant Phil Esterhaus, let's be careful out there.